Sorry, Sertraline, we have a new first-line approach to postpartum depression. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. We began this series on timing treatment with an element that entered the universe in the first few minutes of the Big Bang, lithium. And we're going to end it with a different kind of beginning, childbirth.
Postpartum depression affects 1 in 8 mothers. And early intervention is critical here, not just for the mother, but for the infant and the family. The mother's eyes are the first thing a baby can see at birth, followed later by her face. The baby's vision is limited in those early days. Everything is blurry, it's mostly in black and white, and about the only thing they can make out are 2 black dots about 8 to 12 inches away. In other words, the mother's eyes. And it's through that interaction with their mother that development takes place, from attachment to cognition.
Postpartum depression takes a measurable toll on infant health, causing detriments or delays in language, learning, intelligence, self-control, and attachment. Anxiety, depression, ADHD, sleep and eating problems are all linked to it. It makes intuitive sense that these problems are bigger the longer the depression goes on. But that's not so easy to study. You can't exactly randomize it, and chronic depressions tend to be more severe, which complicates the association.
A few studies have compared children of mothers with similar severity of depression but with different durations, and they confirm the idea that longer durations worsen the outcomes.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. 1. Where does DSM-5 place the cutoff for postpartum or peripartum depression? A. 2 weeks after delivery. B. 4 weeks after delivery. C. 8 weeks after delivery. D. 6 months after delivery. The typical treatment for postpartum depression is an antidepressant, usually sertraline, because that one has the most favorable breastfeeding effects. And there's nothing wrong with that approach. But with a small benefit, only 1 in 3 reach remission on it, and a slow onset of 4 to 6 weeks. There's a good chance you're going to shuffle through a few antidepressant trials and waste a lot of precious time if you go this route. Besides, postpartum depression is a risk factor for bipolar disorder, in which case antidepressants can make things worse.
This is where zuranolone, Zurzuvae, has an advantage. Zuranolone is a synthetic version of allopregnanolone, a hormone that rises during pregnancy and takes a sharp fall after delivery. It was approved for postpartum depression in 2023, and it works quickly, within a few days. It's part of a new crop of rapid-acting treatments that have gained FDA approval in recent years, including S-ketamine, Spravato, and bupropion dextromethorphan combo, Avulity, both of which speed up response in depression. Now, the downside of many rapid-acting treatments is that they don't have a clearly defined end date, and many of them are controlled substances where we might worry about long-term effects like tolerance and misuse.
Actually, the first rapid-acting treatment for depression was alprazolam, Xanax. In the late 1970s, the manufacturer tried to get this benzo approved for depression, and indeed, there are over a dozen studies showing it treats depression with a fast onset, independent of its effects on anxiety. But the FDA wasn't having it. Probably they were too concerned about the risks of this controlled substance and the fact that long-term benzo use can worsen depression. In the end, they approved alprazolam for panic disorder, generalized anxiety disorder, and anxious symptoms during depression, which doesn't exactly put much limit on its use.
Zuranolone acts a lot like a benzo. It modulates the same receptor, GABA-A, and it has similar sedative, anxiolytic, and rewarding qualities as benzos do, which is why it is classified as a controlled substance. But the FDA limits its use to just 2 weeks, which means we don't need to worry about long-term use, and we're going to have to do something to keep depression from coming back after it works.
That may involve psychotherapy, family support, better sleep, and light exercise. A healthy diet, particularly lots of blueberries and fruits, has prevented postpartum depression in some trials, and so has an infant carrier. In a randomized controlled trial from 2023, simply giving low-income mothers an ergonomic infant carrier prevented postpartum depression. It may involve light therapy or an antidepressant, but hopefully the mother will be in treatment so they can start that antidepressant early when the symptoms are mild if the depression comes back.
In many cultures, healing is a ritual that takes place in a sacred space and time under the direction of a shaman. And if this New Age banter has made you want to skip to the end of the podcast, hear me out. They did this because the format worked. And as we've developed more effective therapeutic ingredients, we have lost that format. But with zuranolone and brexanolone, the FDA has approved the first time-limited medications for depression, which gives us the opportunity to recreate the sacred time and place idea. That doesn't mean your patient needs to chant while they take zuranolone, but we can borrow a bit from the traditional healing culture. Shamanic rituals are one-time events, and they come with instructions to maintain the healing after the ritual has ended. In practice, that means you need to lay out a pathway for prevention with the patient before beginning zuranolone, and that might involve bringing the family in so everyone takes part in supporting the mother's recovery and reducing the stress that brought about the episode. For more on this idea, flash back to our June and July 2024 episodes where we interviewed Dr. Kyle Greenway about the Montreal method for using ketamine, which also involves this shamanic ritual, borrowing that idea to boost the therapeutic results after the short-term treatment has ended. Zuranolone works faster than an SSRI, but does it work any better? Maybe. Its effect size is 0.5, that's medium, compared to 0.3, small, for SSRIs. But these aren't from head-to-head studies, so we can't say for sure. But the IV version, brexanolone, has an even larger effect size at 1.2, so that might be the route to go if the depression is severe. Brexanolone, also known as Xarelto, is the original IV version of this drug. It was released a few years before zuranolone came out, but it didn't pick up, partly because it requires IV use, is expensive, and requires overnight delivery for 36 hours at a treatment center. Not exactly easy to do when the drug was released just as the COVID epidemic was hitting, and indeed, only about 1,000 women had received this drug in the first few years of its release. But you can get brexanolone, Xarelto, and it is still worth using in severe cases. You can find a center that offers it through the manufacturer's website, www.Xarelto, that's ZULRESSOREMS.com, because it is a REMS program, or by calling 1-844-472-4379 in the U.S.
But a warning, a lot of times severe postpartum depression is a different illness altogether. It's postpartum psychosis, a psychiatric emergency that happens at 1 in 1,000 births. The psychosis here usually involves paranoia about their family being out to get them in some way, or delusions about the baby's safety. These women are not likely to respond to zuranolone, and an antidepressant is not a good idea here either, as most cases of postpartum psychosis have strong bipolar features. New treatment guidelines recommend lithium and antipsychotics for postpartum psychosis, and you can read more about those guidelines in the March issue of the Carlat report.
3 other conditions that might rise up in postpartum period are OCD, PTSD, and bipolar. Around 1 in 6 mothers develop postpartum OCD, But this diagnosis is a little tricky because half of women with postpartum depression have obsessive thoughts, and they look kind of similar. They're usually centered on the child's health and safety. And when it comes to pure postpartum depression, it's worthwhile to look into a few medical causes, as we always do, but two are particularly common in postpartum cases: low iron and low thyroid. Also, the postpartum period is an inflammatory state. So everything that we've said throughout our podcast series about inflammatory depressions might well apply here. And there is a new study of the anti-inflammatory celecoxib, that's an NSAID, which was effective in treating postpartum depression.
Childbirth is often traumatic, particularly if there are medical complications or emergency C-sections is required. If we look at the matter subjectively, 1 in 3 women experience childbirth as a traumatic event. But the DSM only allows these to qualify as a trauma if the mother's life or the newborn's life was threatened. But not all that is traumatic leads to PTSD. While childbirth is traumatic for 30% of women, only 3 to 6% of women go on to have full PTSD from it.
And you got to consider bipolar disorder here. For a woman with bipolar disorder, the postpartum period is the highest risk factor for having a new episode. Actually, it's an ultra-high risk factor for men as well, with all the changes in sleep and routines that a new baby brings. But here's what you really need to know. If you see a woman with postpartum depression, the chance that she is having a bipolar depression is 25 to 50%. The actual rate depends on the setting. But if you're in a psychiatric practice, it tends toward the higher 50% side. Many women with bipolar disorder have their first mood episode at this time, so having a past history of bipolar is not necessarily a good, reliable guide here. But those who are younger, have a family history of bipolar, or who have experienced mixed or psychotic features during their depression are more at risk for having bipolar postpartum depression.
Psychosis is the more severe side of postpartum psychiatry, and on the milder side is the baby blues, a common brief syndrome of crying, irritability, and insomnia that starts within 1 to 2 days after delivery and resolves within 10 days. Zuranolone is not appropriate here. Most cases don't go on to postpartum depression, though the baby blues is a risk factor for this mood disorder. So if the baby blues begins in the first few days after childbirth, when does postpartum depression begin? DSM sets the postpartum cutoff at 4 weeks after delivery, but for ICD-11, it's 6 weeks, and other groups argue for 6 to 12 months. Actually, in 2013, DSM-5 changed the definition and the name from postpartum to peripartum, so the new DSM specifier includes depression that begins during pregnancy or within the first 4 weeks postpartum.
So DSM says it has to happen within 4 weeks, and the research tells us that it tends to peak at about 2 to 4 weeks. But in my own practice, I tend to use a cutoff of 8 weeks for postpartum depression, which is a little longer than DSM-5's 4 weeks and ICD's 6 weeks. But this 8-week figure is based on a more recent study from France, where the cases spiked between 2 to 8 weeks after delivery. After that 8-week mark, they started to plateau, but they still crept up for a full year after delivery.
The Zuranolone trials followed the DSM approach, with a 4-week cutoff. They also enrolled those whose depression began in the 3rd trimester, although most of the subjects, 2/3 of them, had their onset in the first 4 weeks after delivery. This doesn't mean they gave Zuranolone during pregnancy. It is not indicated then. But it does mean they gave it after childbirth to women whose depression began late in the course of pregnancy. Another limit, Zuranolone has not been tested during breastfeeding, and women have to stop breastfeeding for the 2-week period. That's a shame, because breastfeeding is good for the health of the mother and the baby, and women can lose the ability to lactate if they stop. We recommend a lactation consultant to help here. Pumping and disposing of milk while on Zuranolone might keep it going.
Fun fact. In 1992, Sven Denker and colleagues in Sweden found naturally occurring benzodiazepines in human breast milk. To our knowledge, the finding has not been replicated, although similar reports exist in cow milk, and researchers have also found naturally occurring benzos, very similar to lorazepam, in the human brain. Exactly what purpose those low level of anxiolytics serve remains unknown. Rapid detection of bipolar disorder, lithium for early phase bipolar, clozapine within the first 3 years of antipsychotic resistance in schizophrenia, and metformin at the first signs of significant weight gain on an antipsychotic. Psychoeducation to reverse the phobia after a panic attack, zuranolone for quick relief for postpartum depression. And with that, we close the window on this podcast series, but we are not sealing it. These are just the windows of opportunity that we thought of, and we tried to highlight the ones that are underutilized in our field. Maybe you know of some more. Write us at asktheeditor@thecarlatreport.com.
Want to keep up with the latest in psychiatric research? We post new studies in the daily psych feed. Search for Chris Aiken MD on LinkedIn, Twitter, Facebook, and that new one, Blue Sky. It's a first glimpse of the trials that inform this podcast. Thanks for tuning in and helping us stay free of industry support.